move on to the next presenter, Dr. Chow. Oh, okay, Dr. Chow is here. So, Dr. Chow, will be talking on the challenges of status epilepticus management in the elderly. Just hold on. Sorry. So Dr. Chow, he's a emergency physician from Hospital Seberang Jaya. He's the vice president for the Penang CPR Society, and he's instructor for various courses for BLS, ALS, TLSM, My ENLS, BLSIC, ALSIC, TLSM, and he has so many other courses. Very impressive. So Dr. Chow, if you would like to share your screen.
Okay. Thank you, Miss Diana, for the kind introduction. Morning, everyone. So I'm going to share my slides.
Okay, yeah.
Okay. Right. So today I'm going to talk about challenges of managing status epilepticus in the elderly. So this is the outline of my talk. I go through some introduction, what are the definitions involved in this talk, a bit on the epidemiology of status epilepticus, especially in the elderly. How do we classify status epilepticus? What are the common causes in the elderly? And the highlight of the topic, the unique challenges in treating elderly patients with status epilepticus. So status epilepticus is a neurological emergency affecting all ages from the very young until the very old. But the very old, for the elderly, as defined more than 60 years and above, have the highest incidence and more likely to have more severe consequences than the younger age group. So as we all know that elderly patients is different from younger adults in many aspects, not only from the age, but their health status, their multiple comorbids. So the management of elderly patients with status epilepticus requires unique considerations in terms of epidemiology, their etiology, the prognosis, and also the treatment choices that we are going to choose. So for definitions, we still use the International League of Anti-Epilepsy in 2015. So status epilepticus is defined as a condition resulting either from two things: failure of the mechanisms responsible for, number one, seizure termination, or number two, from the initiation of mechanism. Okay, either they fail to terminate, or there's problem with initiation of mechanism to stop the prolonged seizure, right? So this we label it as time point one, T1. So it is a condition which can have long-term consequences after the time point T2, including neuronal death, neuronal injury, and alteration of neural networks, depending on the type and duration of the seizure. So a very simple operational definition, this is what we are more familiar with, which is a single seizure, 5 minutes or more in length, or 2 or more seizures without recovery of consciousness in between them, right? But mind you, this is only applicable for generalized convulsive status epilepticus. So if we are talking about other types of status epilepticus, let me change to pointer. All right. So if you have focal seizure, then will require 10 minutes of continuous seizure to be labeled as status epilepticus. right? And for absence, it is up to 15 minutes. So 5 minutes is only for generalized convulsive. In terms of epidemiology, the age distribution of the incidence of status epilepticus follows a U-shaped curve. So meaning more incidence over the younger, very young, and the very old. So high incidence in the 0 to 9 years old, then we decrease. We see the decrease of incidence throughout the teens, then begin to rise again, and the highest among the elderly. And you see among the elderly also, the higher the age, the higher the incidence. And 30% of the first seizures in the elderly actually presents as status epilepticus. So this is the graph that demonstrates the U-shaped incidence rate with the age distribution. So higher in the very young, and it drops, then continue to rise again after 60 years of age. And when the age gets higher, the incidence also get higher. But this is different compared to the mortality. Although it's quite high among the less than 10 years old, but the mortality is quite low in comparison to the elderly, where the mortality actually rises with age. So as the years goes by, we see the number of status epilepticus among the elderly is actually increasing every year. So this is the study done in Thailand, retrospective looking back from 2004 to 2012, and we see across the age group, especially in the elderly, the incidence rate among the population is actually increasing. So how do we classify status epilepticus? We can generally classify into two, whether they have motor symptoms or they are without motor symptoms. Then after that, we see whether they are generalized or focal and whether their conscious level is impaired. So among the elderly, focal seizures with or without generalization are more common. So generalized seizure only comprises of less than 30%. But the focal seizure, 30%, focal seizure with secondary generalization is up to 45%. So these are the common causes of status epilepticus in the elderly. So as we can expect, so elderly patients, they are caused mainly from stroke and also metabolic. Whereas for the young adults, their main cause are drug-related, whether due to the withdrawal of anti-seizure drug, maybe because of their seizure well controlled, so the drug was the dosage was reduced, or they defaulted treatment and they stopped taking their drug, or it's due to alcohol related. Then of course, stroke also contributes to adult status epilepticus, but it's almost 3 times lesser compared to the elderly. And study shows that cerebral infarction within 1 year increased the seizure risk by 23-fold in the elderly compared to the general population. So now coming to the unique challenges that we face in the elderly coming with status epilepticus. So I'll be mainly focusing in the emergency department aspect. Number one, of course, the burden of the comorbids. We know elderly, a big portion of the elderly come with multiple comorbid. And due to this multiple comorbid, they come with polypharmacy. So they have a whole table of medication to take every day. And these are the norm in many elderly. And this can present as a diagnostic challenge. Not only they may impair consciousness, older adult may be prone to metabolic disturbances, especially in terms of electrolytes and also glucose disturbances. So we need to investigate and treat the underlying metabolic etiologies to prevent future episodes. So talking about diagnostic challenge, because most of the seizure happen in elderly are often unwitnessed, or rather atypical or have subtle presentations. This often lead to delayed diagnosis. So the atypical presentations usually due to the non-convulsive status, which may be mistaken for metabolic encephalopathy, delirium, or even psychosis and also drug intoxication. So the difficulty in obtaining an accurate history due to the cognitive decline of the patient, or because of communication barriers, and a lot of the elderly are not staying with children. So when they are brought in status, then we cannot get an accurate history and even the medication history. So we need to stress on the importance of EEG monitoring. But however, having said that, the access to EEG and the interpretation can be challenging for most hospital settings. So in younger patients, we see a lot of complex partial seizure. The epileptic focus in the elderly are more often involve the parietal and the frontal lobe. For younger one, usually the temporal, but for elderly, mostly over the parietal and frontal. Thus, the orofacial and limb automatism, the olfactory hallucination, and the deja vu are less common among the elderly. So in comparison, elderly usually commonly present with altered cognition, periods of staring and unresponsiveness, or even blackout spells and dizziness. So their presentation are more subtle and not very specific to epilepsy. So there are two studies, one done in France and one done in Belgium, where they show that 16% of the elderly patients with confusion of unknown origin were diagnosed with non-convulsive status by video EEG, and none of them had a history of epilepsy. And they find that acute onset within 24 hours and lack of clinical response to simple commands were the ones associated with non-convulsive status epilepticus. And in the Belgium study, almost 30% of the elderly patient present with delirium with continuous EEG showed patterns compatible with non-convulsive status. Therefore, we need to have a high index of suspicion and timely EEG to confirm the diagnosis, especially in elderly patients presenting with altered mental status. And the EEG maybe is the best way and probably the only way to diagnose non-convulsive status accurately. So as we know that non-convulsive status is much more difficult to recognize because of the lack of significant motor presentation. So we can look for these common signs symptoms. This includes the subtle twitching of the face or limbs, some nystagmoid eye movement, and also mental status. They can vary from mild confusion to a total coma. And this non-convulsive status may arise as the initial manifestation of the seizure, or it can be the result from the control of the initial convulsive status. So the clinical manifestation of decreased cognitive performance, decreased level of consciousness, mental confusion, and also continuous or fluctuating behavioral changes, especially if acute onset, then we need to think of non-convulsive status. And all this presentation, they have an average duration of 10 hours. Why? Because usually they have delayed recognition and also treatment, because all this presentation can be due to many other causes, especially electrolyte imbalances, glucose, medication. So often the diagnosis of non-convulsive status is delayed, and the non-availability of EEG. So now we look at what are the mimics and chameleon related to status epilepticus. So mimics for focal motor status can include chorea, clonus, dystonia, hemiplegismus, myoclonus, and many other things. For chameleons, we have disorder of consciousness. Patient might be in coma, not due to epilepsy. For it present with coma because of epilepsy and not due to other conditions. Patient might present as aphasia or stuttering, psychosis, mood disturbances, agitation, amnesia, confusion. So all these might be the subtle changes of status epilepticus non-convulsive. And to complicate matters, the elderly can have prolonged post-ictal symptoms as well, including automental status, which can last from hours to days. And this can really confuse with non-convulsive status and could lead to unnecessary treatment with benzodiazepine and the anti-seizure medication and anesthetics. So it leads to an increased risk of intubation and increased length of stay, which are known to have worse short-term and also long-term outcomes. And therefore, again, EEG is useful to distinguish the post-ictal state from non-convulsive status. So in small proportion of attacks, the ictal activity continues acutely, and the post-ictal confusion might be in fact an ictal phase, taking the form of non-convulsive status, right? So this complicates the matter even worse, but we have a few presentations that we might want to consider that this might be a non-convulsive status. So if the patient has hallucinatory symptoms recorded during and after the seizure, prolonged post-ictal confusional state, prolonged post-ictal psychotic states, if the patient has underlying epileptic and other encephalopathies, and coma with or without clinical signs of non-convulsive status. So pragmatically, patients should show some recovery of neurological deficits within 1 hour. Otherwise, we need to consider non-convulsive status. Having said all the different subtle presentation, if patient doesn't recover within 1 hour of treatment, then we need to really consider whether patient has gone into non-convulsive status. Now we talk about pharmacokinetics and pharmacodynamics. So the treatment of status in older adults is similar to that for younger adults due to lack of evidence. Not many papers actually just focus on elderly population in terms of treatment of status epilepticus. And we know that the age-related changes in the pharmacokinetics in terms of absorption, distribution, metabolism, and excretion, and the pharmacodynamics is actually very important. And we know that due to the reduced liver function and kidney function, so there will be reduced drug clearance from the body, and this increase the sensitivity to medications, particularly benzodiazepines. So if we look through the treatment flow for status epilepticus, this is from the Malaysian Emergency Neurology Life Support treatment protocol. So someone come in with convulsive status after the initial stabilization phase in the pre-hospital, then we enter the 3 phases. The stage 1, the initial therapy with benzodiazepine. Stage 2, the control therapy with the second-line medication, your phenytoin, sodium valproate, and levetiracetam, or your Keppra. And if the status epilepticus is still not terminated, then you go on to stage 3, which is the treatment of refractory status epilepticus using anesthetics, and patient will be intubated and ventilated at this stage. So for stage 1 initial therapy, which is the usage of benzodiazepine. So we in Malaysia, we have diazepam and midazolam. So the consideration here is that lower doses should be used due to the increased sensitivity that I mentioned just now. So for young adults, we usually give benzodiazepine, either midazolam or diazepam, 10 milligram. Either you can go through, if midazolam, you can go through different routes like buccal, intramuscular, or IV. Diazepam, you can either use IV or rectal. But for elderly, you need to half the dose, 5 milligram only. Okay, 5 milligram only. And we need to monitor for respiratory depression and also hypotension. So for in general, young adults 10 milligram, for elderly is 5 milligram. And if this paper actually break down the age even further. So if we look at for 60 to 80, they actually use 2 milligram, but they titrate, they go slow, but they give multiple times. For more than 80, then use 1 milligram and titrate. For stage 2, when the benzodiazepine fails, then we will resort to either phenytoin, sodium valproate, or levetiracetam. So the considerations over here is the drug interaction and potential side effects. And we need to adjust the dose based on the renal and hepatic function. And levetiracetam and sodium valproate are the very common second-line agents used in the elderly. So many of us, in many centers, phenytoin is readily available in all emergency department. So these are the standard dosage that we are practicing, 15 to 20 milligram per kilo. And for adult, usually we'll give it fast, over 15 milligram per minute, or if you translate to over time, which your infusion will finish within half an hour. But for elderly, the infusion rate, we need to slow it down to 20 milligram per minute, or those with pre-existing cardiovascular disorder. Why? Because the pH for phenytoin is 12, and phenytoin contains high levels of propylene glycol. So the rate has to be slowed to avoid hypotension and cardiac arrhythmias. So if we look at the drug-drug interaction between phenytoin and warfarin, because quite a number of elderly has AF, and some of them will be on warfarin. So phenytoin and warfarin, they have this what we call a biphasic interaction. We know that phenytoin is an enzyme inducer, but however, in the initial stage, phenytoin actually increase the warfarin dose by displacement from the protein binding. Okay, so this is the initial phase, but subsequently, the enzyme induction take over and increase the warfarin metabolism and decrease the INR. So the initial phase, it will increase the INR due to displacement of warfarin from the protein binding sites, but subsequently, it will decrease the INR. So the initial phase is quite relevant to ED practice, where we usually load status epilepticus with phenytoin. And IV phenytoin is contraindicated in patients with severe heart disease and those with a second or third degree AV block. So in short, those with heart problem, severe heart disease, those with AF on warfarin, then we will avoid phenytoin. Otherwise, we can still use phenytoin, but at a reduced rate. Dose is still the same, but we reduce the rate to 20 milligram per minute. Phenobarbital should be avoided because of its greater central and respiratory depression. Although the safer and the better alternative will be sodium valproate and levetiracetam, but sodium valproate is also associated with hepatotoxicity, so it is contraindicated in hepatic failure. So leaving levetiracetam the safest among all second stage medication. But however, levetiracetam is not readily available in all emergency department. So this chart actually shows how to load the second line drugs. So for phenytoin, we'll be loading at 20 milligram per minute. So sodium valproate for the more than 60 years old, 20 to 30 milligram per kilo in 30 minutes. Levetiracetam loading for 60 years and above, 15 to 25 milligram per kilo over 15 minutes. So if you compare to general adult, young adults, so young adults for sodium valproate and levetiracetam, we are actually giving much higher dosage. So for sodium valproate, we are giving 40 milligram per kilo over 15 minutes for those less than 60 years old. For levetiracetam, 60 milligram per kilo over 15 minutes. So in short, if we are using phenytoin, the dosage remains the same, but then we slow down the rate. For sodium valproate and levetiracetam, we half the dose for elderly, half the dose, and slow down the rate as well. This is a busy slides, but what I want to draw your attention to is over here, the red color part. So if the patient present with absence status, then it favors for non-aggressive treatment. Whereas in comparison to non-convulsive status after a convulsive status or non-convulsive status in coma, that favors a more aggressive treatment. So in terms of prognosis, the overall mortality for status is quite high, almost 30%, and it is age dependent. So the older the age, the higher the mortality, as what we can see from this graph over here. So 30%, 13% in the young adults, 38% in the age group of 60 to 80, and more than 80 is up to 50%. So the mortality rate is getting higher and higher with the advancement of the age. So the major factors in age-related mortality will be the etiology and also the complication of status epilepticus. Because if we see over here, different etiology give you different mortality rate. And we know that the etiology for elderly are mainly stroke, and stroke carries one of the highest mortality in terms of status epilepticus. The highest will be the hypoxia, also severe acute anoxia, which carry up to 80%. If we look at clinical scoring, there are two popular clinical scoring for status epilepticus. One being the STES score, which is the Status Epilepticus Severity Score. So if we look at here, this is a four-component scoring system. So if we look at age, more than 65 years old will carry 2 points. And more than 2 points will become unfavorable outcome. Okay, so elderly come with stuporous impaired consciousness, or it comes with some non-convulsive status in coma. So this will give you a non-favorable outcome. Another clinical scoring will be this EMSC score, which is epidemiology-based mortality score in status epilepticus. Again, it is a 4-component scoring system looking at etiology, age, comorbidity, and EEG. So if for the practice in emergency department, we don't have the access to EEG, but we can look at the etiology, age, and also comorbidity. But if we look at here, if we are using EAC only, excluding the EEG, anything more than 26 points, which is 27 and above, will give you poor outcome. So if the patient come in with acute stroke with status epilepticus, already give you 26 points, 26 points. Then plus the age, then it will give you a poor outcome, right? Because anyone more than 60 will get a point of 7 and above, right? So in summary, the incidence of status epilepticus in the elderly is increasing from year to year and is associated with higher mortality compared to the younger adults. So atypical presentation is very common, and due to the lack of motor presentation, contributes to the diagnostic challenge and often very much delayed treatment. And the most common cause for status in the elderly is, of course, stroke. And we know that the EEG aids in the diagnosis, although the availability is quite challenging. And multiple comorbids, polypharmacy, pharmacodynamic, and kinetics are the important considerations on choosing the best treatment. And the treatment for the patients need to be individualized, not like in the young adults. Therefore, a collaborative effort between the emergency department, the neurology, the geriatrics, and also the pharmacists is very crucial in the management of status epilepticus in the elderly. With that, thank you very much, and I welcome any questions.
Thank you very much, Dr. Chow. Very interesting talk. Anyone has any questions? I was just wondering from my side, because you mentioned that in elderly post-ictal period is prolonged, tends to be prolonged, and you have to differentiate from a non-convulsive status. So in your experience and in the Malaysian setting, because there's no EEG in ED also, where do you go from there? If a patient, you query whether it's a post-ictal or a non-convulsive status epilepticus. So how would you manage, like in the Malaysia setting? Just trying to imagine.
Right. Thank you for the questions, Miss Diana. So, very, very important question. So it's quite challenging for us in ED with a resource limited setting to actually accurately diagnose non-convulsive status, especially when the patient is whether it's in a post-ictal state or non-convulsive status from the initial convulsive status. So number one, of course, if the patient doesn't recover, showing some recovery of the neurological deficit from our initial treatment within the first 60 minutes, then we need to start correcting all the possible confounding factors that could possibly alter the patient's consciousness, especially the electrolytes and also the sugar. Then subsequently, we will need to look hard for any subtle changes, for example, some twitching of the limbs and also the nystagmoid movement of the eye, which we need to retract the eyelids to actually look at the eyeball. Then, of course, the improvement of the vital signs as well, and not forgetting a multidisciplinary approach. We need to involve all the relevant teams early in the management. Our neuro team, geriatric team, and if the patient require intubation, then NS should be on board as well.
Okay. No, thank you. Yeah, I guess yeah, multidisciplinary team would play a big role in that, especially like neurology and NS. Okay. The scoring systems you showed earlier, I was just wondering, when they say poor outcome, does it mean like poor functional outcome or sort of in mortality?
For the first one, the STAT score, actually is a favor outcome and non-favor outcome. But if we are looking at the specificity, it actually more specific for favor outcome. So if less than 2 or less, 2 point or less, then it's definitely patient will have a favor outcome. But the specificity for quote less favor outcome is not that high. Whereas if we are talking about the EMSC score, that will be more accurate in prognosticate poor outcome and mortality. But having said that, we cannot base on that score alone to let's say DNR the patient or what.
Oh, okay. So it's kind of just gives you an idea, but it
Yeah.
doesn't
It's easier for us to like talk to the family member when the family member asks us about prognosis, but we shouldn't we cannot solely base on that to DNAR a patient.
Oh, okay. Okay, sure. Doesn't quite affect clinical judgment in that sense. Okay. Thank you very much. Anyone has any questions? There's no questions so far in the chat box. I think that's all the questions from me. Anything from everyone else? Thank you so much. That was a very insightful talk.
Thank you.
I think if no one has any questions, we can probably end the session. Thank you very much to both of the speakers. Enjoyed both talks a lot this morning, and thank you everyone for joining us this Saturday morning. Think we can end the session. Thank you very much, Dr.
Can I group
Hafizah and Dr.
photo?
Chow. Oh yes,
Can I group
anyone
photo?
can have a group photo, yes. Let's have a group photo. So for group photo, let's see, everyone can, let's see, try and, yeah, so group photo. I think now everyone's in the gallery view, right? We can all switch on our cameras. Okay. Okay, I think, so we have 2 pages. So I'll count to 3. Everyone who wants to open their camera will be great. Then I'll take a photo. Okay, so 1, 2, 3. Okay. Then okay. Then another one, 1, 2, 3. Okay. Okay. So just hold on. Let me just make sure that. Okay. Oh, let me just take another one. No, hold on. Sorry. Okay, just one last one. Be done. Okay, 1, 2, 3. Okay, yeah, done photos. I'll send the photos. Okay, thank you very much.
Thank you, everyone.
Thank you.
Thank you.
Thanks. Bye. So I'll just end the session, yeah?